Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So today I'm talking to Associate Professor Adam Culvenor from Trobe University, and more specifically from the Trobe Sport and Exercise Medicine, or LASEM, Research Centre. So Adam and I went through our PhD programs together. We finished over 10 years ago, looking at knee function and structure and outcomes in people with ACL reconstructions. And I followed my path that you'll be familiar with if you listen to the podcast regularly, to become a teaching and research academic at Monash University Physiotherapy. And Adam's followed a research pathway. So that in itself is interesting in terms of what you can do following a PhD. And for those of you considering a research degree, you can see two different pathways there that involve research. But today we're going to focus on Adam, and we're going to talk about, I guess we're going to steer the conversation more broadly from knee injuries and osteoarthritis to some of Adam's research and what he's most known for. So post-traumatic knee osteoarthritis, the patellofemoral joint, the knee in general. We're going to get a bit of an update from some of the research that Adam's working on, the projects that he's working on. And it's going to be a really good opportunity to hear about some of this research from the horse's mouth, from a leading researcher himself. So it's a pleasure to finally get you on the podcast, Adam. Adam Culvenor, welcome to Physio Foundations.
Thanks, Luke. I apologise for how long it's been for trying to tee up this chat. So here we are.
You're a very busy man.
Great to be here.
Yeah, it's good to have you here. You're a very busy man, and people are about to find out some very interesting stuff about you. But let's just go through who you are first. So you're a principal research fellow within LASEM, and you've got an NHMRC, so National Health and Medicine Research Council fellowship at the moment, which is a very prestigious research funding for those who are outside Australia. And you're the head of the knee injury research group within LASEM. You've got lots of awards. I'll put your profile into the show notes rather than reading it all out. You've got many awards for your research. You've done international fellowships and travel for your research. Do you want to tell me or tell the listeners a little bit more about your current projects and interests and who you are?
Yeah, thanks, Luke. So I'm a physio by background. I don't know whether you touched on that in the intro as well, but have gone down the path of initial career doing a bit of hands-on work in hospitals and private sports clinic and really getting my hands dirty and being a clinician. But always knew, having completed a little bit of research during my undergraduate years at university here at La Trobe, an honours degree, that I really had that itch to come back to research eventually after getting my hands dirty and really having the opportunity to sort of develop interesting clinical research questions and then developing ideas, projects, designing studies to be able to answer those and obviously write them up and disseminate those to try and improve clinical practice and outcomes for patients. So as you mentioned, we did our PhDs together in knees. So my journey started looking at fat pads, actually. So infrapatellar fat pads in the knee and their relationship with patellar tendon pathology, so patellar tendinopathy, and published my very first paper was publishing a small cross-sectional study looking at fat pads in those with and without pain in and around the patellar tendons. That was where my sort of career started a long time ago. And then very much transition more to acute knee injuries, particularly ACL injuries, which I'm sure many of you listeners will know are very common and burdensome with a long time out of sport. And the development of osteoarthritis, unfortunately, occurs in a higher proportion of these patients much earlier in life. So that is really almost a summary of what I've been trying to uncover, is why these young people develop osteoarthritis so quickly in life after having a traumatic injury, such as an ACL or meniscal tear, for example. And then, what are the risk factors for developing that post-traumatic osteoarthritis? What can we do about it as clinicians or through surgical rehabilitation type interventions to try and optimise people's quality of life at that present time, but also long-term as well? So what's the prognostic outcomes and keeping people healthy, active, and doing what they want to do over the long term? So that's sort of my interests and sort of current research thinking and involvement in research projects at the moment. And we've got a number of projects we can explore in a bit more detail, if you like, Luke, in that space.
Yeah. We should acknowledge Professor Kay Crosley, who's the head of the LASEM Research Centre, and also supervised both of our PhDs, and that's how we met. And so there's in Kay's research group and your research group, there's an enormous amount of research output, and you're really changing the landscape of the clinical practice, the way we manage these conditions. So I'm keen to talk about all of that and more. Let's get into some of your work, some of your research publications, and perhaps your foundations. I'm interested, you mentioned fat pads was your first paper. I remember I saw your first conference paper, 2008, I think it was, at Sports Medicine Australia conference. You're up there presenting.
Got a good memory.
Yeah, that was a while ago. And then we ended up studying together, doing our PhDs together. So tell us about that first of all. What did you find out? It's a while ago now, but
making me scrape my brain here. So I spend a lot of that time sort of tracing little markers around fat pads in people's knees from MRIs. So we sort of did a 3D volumetric analysis of people's fat pads, infrapatellar fat pads. So the fat pad that sits behind the patellar tendon in the knee, very important. You could be severely emaciated and have no fat anywhere else in the body, but the fat pad will be one of the last pieces of adipose tissue standing. So it has an important function in the knee. Very, very nociceptive. So there was I think an American researcher who did an experiment where he, not totally awake, so not under any anesthesia, actually opened or had someone open his knee up and started poking and prodding different anatomical structures. And he reported that the fat pad was actually the most painful structure to actually touch and poke and prod. So I think you have to be a little bit cautious of those findings, given the type of human that would put themselves enroll in such a study. It was an N=1, obviously. But that's, just I think underlies the importance of fat pads. And I think that whether it's the enlarged fat pad with inflammation and pressure, exerting the compressive forces on the patellar tendon, or indeed some of that inflammatory milieu that comes from that associated enlargement of fat pads and inflammation. And Hoffer is another name, so Hoffer synovitis, Hoffer fat pad synovitis, enroaching onto the fat pad as well. So
that's research that's done and doesn't have to be done again. But I think made the point that it's extremely painful. And that's interesting. So the fat pad actually is one of the last structures that you'll lose fat from when losing body
seems
fat.
to be.
It's not fat for energy. It's really for biomechanics.
Function. Yeah, exactly.
Yep. So there's an honours size project for those sort of interested in a research pathway. And honours can be a standalone degree at the end of a science degree, for example. In our physio programs, they're often embedded into our work. I'm supervising some honours students at the moment, or the equivalent of honours in our program. And then so from there, that got you fired up for research. That got you really interested in the knee. What happened after that?
Yeah, so I was fortunate to have a couple of amazing supervisors and mentors in that early stage of my research career. So Professor Kay Crosley, who you already mentioned, and we both still work closely with, and really a doyen of sports medicine research in Australia and around the world. And also Professor Jill Cook, who many of you will probably know or her name come across in terms of the tendon world. She's sort of retired officially, I think, from academia now, but certainly as a very strong standing internationally from all of her work in improving outcomes for people with tendon pathologies. And so I was very fortunate to have those two gurus and internationally recognised researchers as my early mentors, and both continued to be mentors for me throughout my career. And then, so as I said, went and got my hands dirty in clinical practice, always wanted to do that for a couple of years. And then there was an opportunity that came up to enroll in a PhD, and there was a little bit of funding attached to one of Kay's projects at the University of Melbourne at the time, looking at ACL injury, ACL reconstruction, patellofemoral problems, including osteoarthritis, and working with a couple of surgeons. It was really a clinically motivated sort of research. These surgeons would often go back in and for people who have had a re-rupture of their ACL reconstruction, they'll have to go and do more surgery, sort of revise the ACL or do some chondral management strategies. And they always would say, it's the trochlea in the patellofemoral joint that seems to be most, worn down or affected by sort of early degenerative changes. And no one really knew why and what's happening in the patellofemoral joint that, we're seeing these really early and rapid changes. also the tibiofemoral, but they were saying sort of more so particularly in the trochlea. So my PhD was specifically looking at patellofemoral osteoarthritis, functional outcomes, symptomatic outcomes, and really lucky to have some funding to be able to acquire a lot of MRIs, which are obviously very expensive, but really give us a lot more information in terms of structure than just a plain X-ray. So we were able to analyze.
You used a state-of-the-art technique at the time, wasn't it, for your MRIs?
Exactly. So it develops these softwares and parameters and sequences are developing rapidly all around the world, different vendors and companies trying to develop new and more sexy looking MRIs and high resolution MRI images. So we managed to jump on the back of that innovation and really get an amazing 3D MRI image of the knee, which you could sort of turn and spin in any which way, and be able to look very intricately at all of the really minutiae of the cartilage, the meniscus, bone marrow, so bone marrow lesions or bone bruises, which occur quite prominently after an ACL injury and reconstruction, as well as some of that effusion synovitis, which are sort of inflammatory markers or indicators of that sort of OA, osteoarthritis, inflammatory sort of phenotype. And we looked at that in people 1 year after ACL reconstruction. So those people who should have gone back and been discharged from rehab and gone back to sport probably at that stage after a long period of rehab, and found that these people, a lot of them actually really have still quite a bit of inflammation, but also starting to develop early osteoarthritis signs in their knee on MRI already at that stage at 1 year. So early cartilage changes, some small osteophytes or bone spurs developing, bone marrow lesions, some resolving as a bone bruise sometimes does, but others sort of and that degenerative type of bone marrow lesion starting to develop. So that was initially at 1 year, and then I subsequently followed them up over 3 years. Had a PhD student when I was a post-PhD. I had a PhD student who then did 5 years. And then we've just had a PhD student actually finish who did the 10-year follow-up of that cohort of 120 people. So it's been a real privilege to be able to get to know these patients over the journey of their 10 years of recovery after an ACL reconstruction and see, surprisingly, actually, compared to the literature, a lot of them are actually doing really well. So a lot of them are sort of 50s and 60s now, or maybe 40s and 50s actually, but doing still active. Not a lot of them haven't put on a lot of weight. Their knees are really healthy. The X-rays are looking pretty good at 10 years. We didn't get funding to do MRIs, but we're still analysing a lot of those outcomes at the moment. But by and large, they are actually functioning pretty well, which is sort of goes against some of the literature. You hear that people 10 years down the track after an ACL injury should have about a 50% or 50 or 80% prevalence of early osteoarthritis in their knees. So I'm not sure what we did or the surgeons did that we worked with, but it seems to be a good group that have relatively few issues.
And that may be those who are engaged with research or also engaged with rehab or lifestyle changes.
Exactly, and there's all those biases, yeah.
It's only ever a sample of everybody, but it's interesting to reflect on the wider population as well. So when you started, we knew from imaging, from clinical observations, we knew a bit about, so for example, we're seeing early osteoarthritis in this group. We don't know why. So a lot of your research is looking at mechanisms. Why do these changes occur? But then you've also looked at trying to change and trying to prevent osteoarthritis as well. And that's probably a segue to some of your other projects as well. So I mentioned NHMRC funding. That's very difficult to get. Very few investigators have. I think you've got over $10 million in funding as a researcher. According to your profile,
probably,
maybe
like
more
that
now.
Across a number of different projects, yeah.
So for those not involved in medical research, you're chronically underfunded. That's just an enormous amount of funding, particularly for a physiotherapist in medical research. So you've done a lot in 10 years since your PhD. And some of that has been not just exploring mechanisms, so why things are the way they are and why they occur, but can we change them? So intervention research. An open question. Tell me a bit more about it. So tell us about your investigator grants, your leadership grants, and we can lead into other projects.
Yeah, great. So maybe following a little bit chronological might be helpful for my brain.
Sure.
Hopefully helpful for your listeners' brain is that because I had such a great and keen interest in this imaging side of the research, and it was quite a new area looking at MRIs and finding these early changes and potentially trying to prevent them. Now we know they're, at high risk of happening. I actually managed to secure a European Union Research Council postdoctoral fellow. So I actually went over to Austria ended up being 4 years over there into a musculoskeletal imaging group. So they were a group of anatomists and medical doctors and some engineers, actually, because there's a lot of playing with images and developing automated segmentation algorithms. So very much a sort of an engineering mathematics background needed in that space as well. So again, really extended myself in imaging, not only the types of sequences, but also the types of outcomes we can use to assess structure. So not only sort of cartilage damage, we can look at cartilage thickness. There's different types of mechanisms. We can look at the cartilage quality, so the water content of cartilage, or the proteoglycans, or a protein that indicates cartilage health. So thinking sort of T2 mapping, T2 relaxation time mapping as one of the most popular in that space. So that just sort of further extended my learnings in the imaging world and continued to have an interest in that. But I think to segue from that, then coming back to La Trobe here, once I got the NHMRC, my own sort of fellowship to continue my line of research, I think it was important to recognise that imaging doesn't necessarily drive a lot of why patients are in pain or seek care as well. So the burden around knee injuries or disease in general isn't just what people have or see on imaging, such as MRI, but particularly in pain, symptoms, functional capacity, disability. That's why people present to medical care. And we know that some of our work we've done, there's actually not a great match between what people see on their image, such as an MRI, and what people experience in terms of pain and symptoms. You can have a terrible looking MRI and no pain. You can have a lot of pain and have nothing wrong with your image, so to speak. And so we started to develop, like you said, some interventional programs to try and prevent this early osteoarthritis developing in young people when they've got a whole life ahead of them. And so that led us to, and Kay was heavily involved in this as well, in developing what we call our super knee intervention. And so that's funded by the NHMRC to run a randomized controlled trial, which we're currently just analysing the data for and writing up at the moment. So I won't spoil the the results, but they should be out very soon. But essentially, we had over a number of years recruited 184 people who were between 9 months and 3 years after their ACL reconstruction. And these people were those that had ongoing problems with their knees. So they weren't yet back to playing sport. They had ongoing symptoms and issues with their knee. They may not have done a lot of rehab. We did recruit quite a bit through COVID, so access to care was limited, which was quite shocking for me personally to see how deteriorated or deconditioned some of these young people were, having not done a lot of rehab, and they're already sort of 9-12 months plus post their reconstruction. And so
during the COVID phase, they were really limited in terms of going to the gym and
we tended to notice that a bit, with all the lockdowns here in Melbourne. And so the program is really a very intensive and progressive strengthening program, with a little bit of evidence that led up to that showing that actually if we address strength impairments, we might be able to have an impact on people's structure, so their cartilage quality, reverse some of these early changes that we were seeing in the cartilage health, as well as obviously a lot of evidence building on a number of years in the knee osteoarthritis space around the importance of exercise, weight loss, lifestyle interventions for improving people's pain and function in older individuals with osteoarthritis. We sort of brought that forward and adapted that to a younger population. So these people have young kids, they're working, so really had to try and incorporate all of those challenges in developing an intervention. It was supervised by a physiotherapist, so we trained up a number of physiotherapists in the community and compared that to a really low intervention or just a bit of education in the other group, and followed them up at 4 months and 12 months, and they're undergoing 2-year follow-up at the moment, and then 5-year follow-up will start in a couple of years. So the aim is, again, to follow them up longer term to see how they go later in life as well.
There's no simple answer to this, but how does strengthening help with cartilage health, particularly after injury?
That's a great question, Luke. A very complicated question, and we don't really have a good answer yet. What I will say, though, is that contrary to historical beliefs where we thought that osteoarthritis and cartilage is simply just a wear and tear type disease where we just, stand up, walk, run, we play a lot of sport on our knees over many years, and eventually the cartilage will just wear down, and it's just a symptom of older age, and we can't do much about it. So don't load your knee too much, otherwise it'll wear out. What we now know is that that's actually not very accurate from a lot more other research, and the cartilage is actually very dynamic as a structure. So you have very thin hyaline cartilage that surrounds the edge of the synovial joint, such as the knee, but it's really important. Offers a lot of prevents a lot of friction, so it's a very smooth surface. But it almost acts like a sponge in a way, where it doesn't have a blood supply, so it gets a lot of its nutrients from the synovial fluid within the joint. And we know that if you underload or unload the knee, for example, if you go up to space, and astronauts have done these experiments where they go up for months, come back, and their knee is actually not in a great, their cartilage is not in a great condition because of anti-gravity, they've unloaded their knee. And they've done similar experiments in animal models where they break a leg of a mice and to see how their cartilage is when they offload it. So we know that cartilage, it's really important to load cartilage as well, and unloading is just as detrimental to overloading. So it's a really dynamic structure. Getting that sort of sweet spot right is sort of the overall goal. We don't have enough information to know exactly what that is, and it probably differs for everybody. But certainly we've done a bit of work here at La Trobe and led by Anthony Shaki and Praz Sutheran, biomechanists, who have looked at how people walk and run after their ACL reconstruction. And we find that those who actually underload their knee compared to those who load normally are actually more at risk of developing these early osteoarthritis changes. So previously, as I said, we've thought it was a very much an overloading wear and tear type condition, whereas we now know that in this post-traumatic group of young people, it actually might be more detrimental to underload and not load your knee sufficiently. So as physios, we've developed this program, and I think we've probably not traditionally probably been very good at loading these sufficiently. So progressive, intensive loading, and maybe we've been a bit cautious because the surgeon says, don't do any open chain exercises or whatnot for X number of weeks. And of course, we don't want to re-rupture the graft, but I think there's some thinking and space in clinical practice where we can actually, cautiously but confidently really load these people up. And that's been a model of colleagues of mine over in Norway, where they have outstanding results after ACL injury with their rehab. And they say one of the reasons why is that they're loading their knees up to really quite progressively in strengthening training, that is, to get them back to physical performance. So very interesting.
Yeah, it sure is. Take somebody who's underloaded, maybe during a period where they couldn't go to the gym during COVID, but in general they're not loading their knee enough. Then take somebody who's going through a progressive strengthening program and having higher loads. We expect over time for the person with higher loads to have a better quality, more healthy cartilage, because it's this dynamic, living, spongy tissue. It's not a bearing in your car, like a bearing in your car that's going to wear out eventually.
Yeah,
So
and that sort of you'll have to bring in the other risk factors for osteoarthritis, such as obesity and being overweight, which is another really strong risk factor. And then you sort of counter that argument to say, well, isn't that more load on the knee, and that should be good for the knee if you're overweight. But again, that's a little bit more of a complex conversation where you have a lot of inflammatory sort of phenotypes or an inflammatory part of the knee osteoarthritis disease. And we know that adipose tissue is a very strong inflammatory tissue. It releases a lot of cytokines, which are released into the blood and can affect all joints as well. So we know that overweight people get osteoarthritis in their fingers and their hands much more commonly than, say, healthy people of a healthy weight do. So it's not just about the load, mechanical load brought about from being overweight or obese, but it's actually a bit more complicated with all of the cellular stuff as well.
Yeah, really interesting and a great summary of a throw-in question that I didn't warn you about. That's fantastic. So the Super Knee RCT, we just have to wait for the findings to come out, but you've given us a really nice summary of the rationale and what led up to that study. What else? I've got here, maybe I was going to read out a list of some outputs and studies that you've got on your profile, but why don't you tell me what would the next thing you'd like to talk about?
Yeah, so a few things in the ACL sort of space, and then maybe I'll start with something that's a bit different because that sort of segues a little bit from that inflammation space. So we're also working with a group of dietitians and Professor Peter Bruckner, who many of you may know from clinical sports medicine textbook, Bruckner and Kahn. So he's the Bruckner in that textbook, has had a real passion over the last few years of low carbohydrate diets and helping people with chronic disease, so diabetes, a whole lot of rheumatological conditions, and also osteoarthritis. So there's very little evidence around whether we can change people's course of disease through diet as well. Traditionally, it's been about weight loss diet, as I said, because overweight and obesity is a big risk factor for osteoarthritis. But we've actually got a clinical trial that's almost completed as well, looking at 144 people with osteoarthritis of their knee and comparing an anti-inflammatory diet, well, it's a low carbohydrate diet essentially, compared to a normal sort of think of the food triangle, healthy eating guidelines with all your pastas and rices and breads down the bottom there, 5 serves a day. So comparing those two, so a normal diet, low fat focused compared to a low carbohydrate diet for people with knee osteoarthritis, with the aim of actually changing people's inflammation, chronic systemic inflammation that have developed chronically. So we take blood samples of these people, look at all of the inflammatory markers, as well as, of course, all of the main symptoms, function, etc. And also do a DEXA scan too, so look at their body composition and adiposity. So that's super interesting. So that's also watch this space for that clinical trial to come out. So that's sort of a separate interest of mine with anti-inflammatory sort of that's been developing, working with Peter over the number of years, and low carbohydrate diets.
It's the what about question. Great. Well, you're looking at loading, you're looking at cartilage and physical activity strengthening, but what about diet?
Yeah,
so
exactly.
You're going there as well.
Yep. And so back in the sort of ACL space, we've done we've got the Super Knee program. We've just done a consensus statement called OPTIKNEE. So that was
on
a group
my list. There we go.
Yeah, on your list. Great. A group of about 40 international scientists and a couple of patient partners and clinician partners got together during COVID. So it was all online meetings over, I think, 6 or 7 meetings over a course of a few months, backed by a number of 6 or 7 systematic reviews that we'd done over the past year or so. And so got a group of these experts together to really disentangle, what's the best evidence out there to develop and summarize that into recommendations, both clinical recommendations. So for clinicians treating these patients, who is at risk and what patients should we target with some interventions to prevent osteoarthritis after an ACL or any sort of traumatic knee injury. What should we use to measure outcomes, for example, from a patient reported outcome measure? So which questionnaires are best to use for these patients? What strength tests are best to use, functional tests, and also the types of interventions. So for someone with an acute injury, should we be sending patients straight to surgery to have a surgeon consult? When shouldn't we be doing that? When is rehab first the best option? And what does that rehab sort of look like for clinicians? And then also some research recommendations for those in the academic space around where we feel like the field is going and the sort of low-hanging fruit with which to pick. If people were sort of fresh researchers, that's sort of a great resource to go, actually, where are the evidence gaps identified from all of this work around what's most important to sort of tackle next. So that was published in BJSM 18 months ago or so. And that was a huge undertaking, but something, Jackie Whittaker and I, who's an associate professor at the University of British Columbia in Vancouver in Canada, are really passionate about and very proud to sort of have that whole group come together and output a lot of these best evidence and recommendations. That's one sort of not research specific project, but very much a consensus sort of international group where we're sort of moving into looking at knowing that, I should summarize, a lot of the patients and physios who were in the Super Knee trial actually said, this is a great intervention, but why wait until we're 9 months or 1 year down the track? Why don't we bring this upstream and give it to people, more acutely post-operatively or straight after people's injury, obviously with the proviso of some of those, being cautious about an initial recovery. And we also know from around the world, big clinical trials, that when you have an acute ACL injury, when you compare early surgery against rehabilitation alone, so not having surgery, but then having the option to have surgery later if the knee's not doing well a few months down the track, those two treatment programs put together, there's actually not any difference for most people in terms of pain, symptoms, return to sport, more surgery, meniscus tears, etc., osteoarthritis, a long way down the track. So those two aren't much different. So in Australia, we sort of tend to have a little bit more of a preference at a population level for people having surgery for an ACL injury. People sort of rush to have reconstruction, sort of watch this space again, but sort of future ideas. And alongside that, we've got our knee injury inception study, or sort of almost like a registry of sorts, where we're collecting online information or questionnaires from anyone from around Australia who has had a knee injury in the past 6 months.
I need to stop here, because if you are taking notes or bookmarking things, this is the original email thread between you and I. So
exactly.
Let's do this, and I'll cross promote your Australian knee injury study.
Great.
And also, why don't we just talk about it on the podcast? And so, if you're involved in any way in patient care, or your education, or in research, and you want to contribute to this, how can people get involved?
Yeah. So basically, we're trying to understand a bit more around what people's diagnostic and treatment pathway is that they've experienced from around the world in different states. So how did you get diagnosed? Who did you see? When did you see them? Did you have an image? And then did you get referred to surgeon? Did you get referred to physio? How much rehab did you do? When, if you had surgery, sort of why, sort of understanding the treatment pathway, because we don't really have a good idea. Again, going back to that question around why do we sort of tend to have a preference for surgery in this part of the world, maybe more so than other parts of the world. And so anyone around Australia who's had a knee injury, acute knee injury, so you've have to sort of had something happen to your knee that there goes my knee, not just a chronic sort of slow building pain over time. So an initial incident that's caused you to have an injury in the past 6 months. And those people, we would love to have their insights into their diagnostic and treatment sort of experience. And all you have to do is fill out 5 minutes of questionnaires online, asking about your injury history, your treatment experience, etc. when you first come into the study. And I'll share the website and registration details in a moment. And then we send out sort of further follow-up questionnaires for only 5 minutes when you're 6 months down the track, 1 year down the track, and then a couple of years later as well, to see how you're going longer term. And so to pass on any detail, or register yourself or pass on the information to anyone who you know who has had a knee injury in the past 6 months, just need to go to our website, our study website, which is kneeinjurystudy.com.au. Sorry, say that again. Hang on, Luke. You need me to check. I think it's www.kneeinjurystudy. I think it's .com.au.
Get back to the email chain. Don't worry, it's going to be in the show notes. That's the one, kneeinjurystudy.com.au.
Yeah, exactly.
I put the link in the show notes anyway.
You've made me second guess myself.
You had it. And so has anything like this been done before on this scale?
It's
in Australia, that is. I know that this is
no,
in
not
other
really.
countries
No,
it has.
there's been many years of trying to get a surgery register up and running. So basically a central database of everyone who's had an ACL reconstruction. But that is still in the pipeline. So we've sort of just more interested in this study to understand actually what leads to people getting to that point. So not so much what are the outcomes for surgery, but what's the experience or diagnostic and treatment pathway that leads to someone to have surgery versus choose not to have surgery, if you like.
Yeah. You've done a lot of work engaging with health professionals, researchers, but this is really for people with knee injuries.
Yep.
In the last 6 months, any sort of knee injury, and it's all online. So they'll go
all online,
and that need to come and do a 3.5 hour biomechanics testing session like you and I made people do for our PhDs.
Exactly.
They'll do some follow-ups online.
Yep, exactly. So super simple. There's a video and more information on that website. www.kneeinjurystudy.com.au. And there's a register now button. Just click through, and any issues at all, there's our contact details on that page that people can reach out to us as well. So super excited to get as many people. We've got about 250 people who've involved so far, and range of experiences, which has been really interesting from all different states and territories around Australia.
You've really answered a lot of the questions on our list with you talk really well. You're a really good science communicator. So it was easy for me. I can just ask you a few questions and let you rip. Why don't we bring it back to the listener here and try to summarize some key takeaways from your career in research so far, and maybe from this episode at least. What are some key takeaways you'd like listeners to remember?
Yeah, I always struggle with these takeaway type questions.
Well, people can always rewind and listen to what you've already said.
Exactly. I think some of the work we've done in the imaging space is really important in that, like I said before, it's not, don't over rely on an image.
Yeah. In
the osteoarthritis space, in the ACL space, or other than the diagnosis of an acute injury to start with, if the results of an image isn't going to change how you treat that person, or you're not using it to rule out an important red flag, for example, then just really sit back and question around the need for the image. There's been, I know, some work in the back pain space that for people who do have an MRI of their back, then they're more likely to have worse pain in the future compared to people who don't have an image. So although that sort of perfect diagnosis feels really good, you put people in a box, it's often not productive for patients, and we have that experience in the back.
You can ask who the image is for.
That's a good question, probably. Yeah, exactly.
Who you're serving by getting it done. The OPTIKNEE consensus work that you've done will have guidance there, and all the links to these will be in
it. Does, yeah, and it has a
well.
specific some recommendations there on imaging. I think that's just really a really good go-to resource for all things acute knee injury, sort of early osteoarthritis. I'll also plug my colleagues, Peter Bruckner's. They're just writing almost about to publish a new clinical sports medicine textbooks, the next edition. So there's going to be a whole dedicated chapter on that around post-traumatic osteoarthritis as well, which is going to be a new addition to this edition. So more information can be found there.
And then the next step for our student listeners is buying the textbook. Because there's been a trend away.
I don't get any kickbacks from Brookie.
Oh, look, neither do I. We're not that specific textbook. That one is on our reading list, but there's just a little bit of a trend for less engagement with traditional forms of learning, textbooks, for example, and
they still exist.
And maybe we've got so many 7-second videos to digest that it can be a little reminder to go back to the good quality resources in your studying. But before I soapbox on that, let's return to the conversation. But yeah, so that's the Bible of Sports Medicine, Bruckner and Kahn's Clinical Sports Medicine. New edition is coming out, and your group will have a lot to do with that.
Yeah, no, it's super exciting. Yep. Otherwise, I don't think there's too much more to add, but happy for people to reach out to me. You're happy for me to share my details in the show notes or whatever, Luke, and very happy to, if anyone is interested, a clinician out there interested in doing some more research, we're always interested in supporting young physios and other health professionals to get exposed to research, and there's opportunities to do honours, to do a master's by research, to do PhDs. We're always on the lookout for keen, want to be researchers out there that we're very happy to support and chat to. So
fantastic. Yep. So, and take advantage of those offers. You can track Adam down through his research profile. That'll be in the show notes, or a Google search. And there's a lot written online. There's a lot of resources people can have a look at. So that's a really good overview and summary. Adam, thanks very much. You've come on, you've done a podcast. I know listeners can tell how busy you are. You're leading up a research centre, you're publishing all that research. Thank you for all the work you've done for our profession in terms of leading that field of research. I know how hard you work. If people just see your name and they don't know who you are and they just see the papers, they're just seeing the product of all that work. But I know how much effort you and the research team put into this, and so we're grateful for that. And thanks for coming on and sharing your experience and knowledge with us today.
It's all a bit of fun, Luke. Yep, it gets me out of bed in the morning and pays the bills, and it's very exciting. And yeah, it's great to be around a whole group of very smart people that stimulate you every day to answer different questions and try and solve problems. So very happy to chat. And
the next time I see you will be in the Buffalo Stampede marathon that we're doing up there.
Probably keeling over, about to blow up in some way.
See you on the start line or the finish line. We're both looking worse than we are now, but It should be a lot of fun.
Thanks, Luke.
Great. Thanks a lot, Adam. So like, share, subscribe, do all that sort of stuff, but do get behind the Australian Knee Injury Study and refer that on and get your patients and other people in your networks involved in that. That's a really good thing that Adam and team are doing. Connect with me at Periton Physio or at Luke Periton Online. And until next time, this is Adam and Luke wishing you all the very best with your studying, professional development, and lifelong learning.